And now it is my great pleasure to introduce our final speaker for this session, Dr. Dunja Maria Baston-Bucht from the University of Düsseldorf in Germany. And Dr. Bucht has been active in assisted reproductive technologies in Germany since 2008. And she's part of the FertiProtect network, and she runs the cryopreservation lab since 2018. And so she's going to share with us how that works, and this will provide a wonderful example for us for how it might look for us as we move forward in the US. So Dr. Bucht.
So then, thank you very much for the kind invitation and for the kind introduction. It's really an honor to be here, and to be honest, I didn't know that you just started with transplantation. So it's my shame, because we do a lot of transplantation, and I will answer, I think, a lot of questions. Then let's start. So here's my agenda. First, I was asked to talk about our regulations, and I think that's really boring because we have a lot of laws, a lot of acts, a lot of guidelines, and I will show you some of them. And then I will talk about our network and about our register. That's FertiProtect, that was already named. And we have all these data about the female. So we have got a lack in the male patients, but we have the female data already. And then I will show you our own experience and our own transplantation and our own transplantation mobile service. So what we do is we travel around and thaw on-site and transplant on-site. So then, yeah, I think you know that dog, the German Shepherd, and it's always asked, do you have a license and do you have a registration? So we have got a Medicinal Products Act, we have a Tissue Act, we have an Embryo Protection Act, and that really needs a renewal because it's about 30 years old now. And what's really important for Germany is that oocytes and sperm belong to the pharmaceuticals and the medical associations too. The inspectors can be physicians, and that's quite easy, as well as biologists, but they can be pharmacists. And all the pharmacists want to know, do you have a quality assessment, for example, for oocytes? That might be a problem. So it's easier for us to show our data on embryo evaluation, and even easier as on oocyte evaluation. And regarding the insurances, so infertility centers and cryobanks as well can be part of the common insurance system or can be private, and can also be, as ours, be in a university setting. So in March of this year, we had a change, and now ovarian tissue is officially declared as a tissue. And now I also need to apply for this permission, and I will show you some of our forms needed. First of all, I will give you an introduction of what is prohibited in Germany, because it's very different from the US. So oocyte and ovarian tissue donation is prohibited. Embryo donation is limited and only performed in the south of Germany. Perhaps you know that it's Bavaria, but very limited. Surrogacy is prohibited. PN stage donation prohibited. The number of 2 PNs that are cultured in the ART lab for IVF, ICSI, and frozen ET cycles is limited. So normally we are allowed to culture up to 6 2PN stages, and in some cases, some special cases, even all. And postmortem use is strictly prohibited. So now I need to apply for this permission too, and I wait for the inspectors, I think in fall or in winter this year. So I need adequate rooms, including storage and space. I need these technical devices, you know that. I need a laminar air. Some areas also do need clean air conditions. We need a fridge, a freezer, and we need liquid nitrogen. We need this well-educated staff, and that's similar to your regulations. The team must be named, including a CV and a job description. And I need a cooperation agreement with every surgery unit. And for example, for our cryobank, I've got about 40 surgery units externally. I need contract documents with the patients too. And the storage needs to be monitored with an alert system. And obviously, we need quality management and quality assessment. So what about our patients? As already mentioned, that's part of the Transplantation Act. We call it a donation file in Germany, but it's not a real donation. We need the medical history of the patient and need to decide if she or he is eligible for the treatment, looking at the 5-year survival rate, for example. Then we have this medical briefing, and we need time for consent, especially in the adults and especially in the children with their parents. So the parents need to decide. Then we need a negative serology in case we are going to freeze ovarian tissue for HIV, hepatitis B and C, and for syphilis too. For sperm and oocytes, also the HTLV serology. So if there is any female patient, for example, with HIV or hepatitis, then we can also use M2 freezing. So that's allowed with a keratin tank. And that's very important, as part of the certification as a cancer center of A or B level, it's mandatory for the patients that they need to be counseled with about fertility preservation and with a reproductive specialist. Now in the next part I'm going to talk about a register, so that's FertiProtect. On the side you see this little book, and unfortunately it's only in German, but it's really a good guideline. So it started as a voluntary network about 15 years ago, with some centers, about 10. Now we've got 158 centers organized in Germany, Swiss, and Austria. You can see the list of all centers on the website, and that's really important for the physicians and for oncologists. Members of the editorial board, as well as members of FertiProtect, are authors of guidelines, of books. They organize workshops and meetings and try to share all the experience. And we have this wonderful register of treatments in the female patients. We've got 3 MEA cryobanks for ovarian tissue in Germany, and these are the locations. So it's Bonn, Erlangen, and Düsseldorf, and these are not competitive. So we've all got nearly the same numbers to freeze each year. You just talked about the cryomedia before. So Bonn and Düsseldorf, we use a multi-purpose handling IVF medium supported with DMSO, and Erlangen uses one added with ethylene glycol. So that's not a secret. As a tool, for example, that was just designed by the group is this traffic lamp, and here you can see the risk for premature ovarian insufficiency according to the chemotherapeutics planned for the patient, and it's very worthwhile to know that. Okay, what about cancer and FertiProtect in Germany? So we've got about 500 new cancer cases each year, independent from age and independent from sex. And these are all our consultations and interventions. So the orange ones are the consultations, and that's about 1,500. And the intervention performed is about 1,000 each year. It could be better, and we work on that still. So we try to inform all the pediatrics, all the oncologists, just think about that, especially those that are not working in a cancer A-level center or B-level center. That's the age distribution during consultation, and you see most of them are during their reproductive phase. And yes, we also consult children, and that's very important. Those are the diagnoses at the consultation. So in most cases, it's breast cancer in Germany, followed by lymphomas and leukemia. And there are also some benign diseases, for example, sickle cell anemia. And I think that's the most important one. So these are the data to the number of ovarian tissue cryopreservation and transplantation. So starting in 2007 up to 2020, we've got about 4,000 tissues cryopreserved. And you just need the time for the patients to be cured and just to finalize their treatment. So it's about a storage duration of about 5 to 10 years. And we've got now about 300 tissues transplanted already. Okay, so this one is a little bit difficult. These are transplantations in orange in total, and the green or blue one are the transplants that were transported overnight. So as I mentioned, we've got these 3 Magee cryobanks in Germany, and everybody can send the tissue to us. That's possible. And we've got better results in the case the tissue was sent. So it's sent in an organ transplantation medium called custodiol in between 4 to 8 degrees overnight. And I will show you the boxes too. And here you can see, starting from the left to the right, the endocrine activity after transplantation is between 70 to 85% per transplantation and even per patient. The pregnancy rate is about 20 to 30%, and the live birth rate about 20%. I need to mention too that these are not all ART babies, so these are spontaneous pregnancies in most cases. That works very, very well. But this one is also not that easy to understand. So these are the success rates, but differing in different age groups. So the best results, the younger the patient is. So between the age of 17 up to 33, we've got very good results and declining results in the older one. So that's the time point of cryopreservation and the age at cryopreservation. Okay, now I will give you some more insights and some more details on our work in the center. So the cryobank is called Oncofertility, and you see that above the names of all our departments. So it's Oncofertility is the infertility center, Oncofertility is the cryobank, and Onipit is the PGT unit. And we designed some flyers for our patients. So it's really important to inform the patients and to give them some data and give them phone numbers so they can call us, and we've got a 24-hour hotline, especially for those who have questions about that. This is the one for the external hospitals, so with a short information what to pay attention on in the surgery and who to call in case of transportation, for example. This is the one for the male patient, and the male samples are all frozen in the ART lab. And this is the one especially designed for children. So it should be more simple for the children and for the parents, because they have a lot of information and they need to decide on a lot of things, and therefore it's more easier for them to understand. Thankfully, we've got this teamwork at our campus, so that we've got a task force for fertility preservation consisting of oncologists, of surgeons, gynecologists, urologists, andrologists, endocrinologists, pediatrics and pediatric surgeons too, internists, rheumatologists, and the cryobank as well. We designed some central SOPs, and these are very important, so everybody knows who to call if she or he sees a patient, and what are our phone numbers and who are the contact persons. And in our schedule, we have daily counselings for patients pre and post-treatment, and even male patients can be seen daily. That's no problem. And the counseling of the male patient, that's something special in Germany, that needs to be done by the urologist or by the andrologist. So therefore, we are just the cryopreservation unit. Here are some of our data regarding the fertility preservation. So starting with the female between 2019 and the mid of 2021, because also we need to apply for the financial budget of the university. So we had about 100 counselings in the female. We had M2 freezing for fertility preservation between 16 and nearly 30. Freezing of ovarian tissue, you can see that, so only our cryobank, 168 in 2019, 137 in 20, and 71 until the mid of 21. Patients with a surgery in our OBGYN unit is about 1/3 to 1/4 of all these patients treated. In the male patient, you can see here the freezing of sperm. It's about between 40 to 50, all about, and only one with azoospermia in the ejaculate and then moving forward to TZ. What about the financial aspects? And I heard a lot of your worries about that in the US. That's our system now. So starting from summer last year, the financial aspects changed, because before the patient had to pay that on their own. But it's really cheaper than in the US. I'm sorry for that. Okay, so regarding the insurance pays for M2 oocytes at the moment in the female patient if she's hormone receptor negative and she's older than 18. Because the medication is only allowed in patients over 18 years. That's the problem. And sperm and TZ in the male patient is paid starting at the pubertal age. So what about the children? This one is about the children. We've got a private foundation, and we are very happy about that, to offer the parents really a financial support at that moment. And ovarian tissue at the moment is excluded from the regulations, but I hope that there will be a decision in summer or fall of this year, and then the costs will also be covered. But they just need to decide on that. And some of our clinical studies also support the fertility preservation in the young boys. I looked at our data in the girls, and between 2018 and 2022, we've frozen about 29, or tissues of 29 girls between 1 and 13 years old, most of them suffering from Hodgkin lymphoma. And unfortunately, we've got a loss of follow-up in the cancer registers. So patients with pediatric cancers are not shown in the cancer registry of the adult, and that is a problem with the POF. And therefore, I looked at our data about POF. So nearly 1/3 of patients counseling the UniKit between 2021 and 2022 suffered from a malignancy in their childhood without any case of freezing. And that's really a problem. And I hope that with this will get better in Germany too. Okay, now I will talk about the technique as well. Here you can see some of our special features for the external hospitals. So always try not to biopsy the site with an active corpus luteum, and please don't use any kind of coagulation on the biopsy. That's really, really harmful. We don't need that. Or in case of a bleeding, just take that on the remaining part, but not on the biopsy part. Because you can really compare that with a fried egg, and you will lose the edge. It's really hard, and you can't prepare that for cryopreservation. So the oocytes, the follicles, they are heated. They are damaged. Here you can see one or two photos from the surgery. So just using scissors, that's no problem, and you even don't see any kind of bleeding. Okay? For M2 oocytes, the vitrification is the gold standard in Germany too. What about our overnight transport? So these are our boxes. We've got blue boxes, and the transport services already know that now. You can see some cooling devices, and these keep the medium cool between 4 to 8 degrees for 24 hours. They can be transported nationwide. So we've got a nationwide service, and that's possible for all of our 3 banks. So proceeding with the tissue, from the surgery to the transportation, and then starting with the preparation of the tissue. So here the medulla is resolved, and we try to freeze about 10 strips for each patient. If we've got more, then we will freeze more. And what we also do is we have some biopsy punches. So in between 6 to 9. And these small biopsy bunches are used for vitality assay. They are used for research and also as a quality control for freezing and thawing. So before transplantation takes place, I'm going to thaw these quality control samples. Here again, and below you can see the vitality assay. So the tissue is digested with collagenase and stained with calcine, and you see all these pretty little green dots. These are all follicles of different stage. Whole of the process has a duration of about 4 hours. So starting from preparation to pre-cooling and cooling in the machine with a slow freezing method, vitality testing and storage, it's about 4 hours. And I'm able to freeze 4 patients at the same time in 2 machines. Because I didn't know if you've just all seen an ovary, I've got some photos for you. So perhaps you can just divide on the surgeon who performed that too. And you can see they are just of different size. So the dish is all the same. That's 100 millimeter dish. And they differ in size. And that was really fantastic for me to see because in the ultrasound scan, I think they all look like the same. But they don't in real life. They are all different. And that's very special about this tissue. Here are some more photos. Okay. Now, I'm going to show you some of our data about transplantation, and I think that's very exciting for you too. So, in case of a transplantation, we first ask, do you have a sperm analysis of your partner? Because there must be a child wish at the moment. So this tissue is not replaced in case of hormonal activity only. Starting the procedure, we try to look for the function of the tube because we want a spontaneous pregnancy, if it's possible. And the thawing and the transplantation should be optimal fitted. So I need about 1 hour to thaw the tissue, and the surgeons need about 10 to 15 minutes to prepare this window you can see in the first 2 photos in the peritoneum. So we don't put it on the remaining ovary, we put it in the peritoneum of the functional tube site. In the third photo, you can see all the strips that are planned to be transplanted are just put it on the uterus. And then piece per piece is just transmitted to the window. And therefore you need to pay attention on the orientation. So the cortex should look to the tube, and yeah, that's very important, and that's also my job, because some of the surgeons are not sure about the orientation and if they do that the right way. And especially here too, no coagulation at all. Never, ever. The photo below on the right, that's a follicle. That's a growing follicle in the peritoneum, and that works. That's really wonderful to see. So here are some facts about our transplantation. In the last years in Düsseldorf, we transplanted 45 in 44 patients, so one patient twice. And surgeries performed in Düsseldorf were 24, so we've got 21 to drive around in Germany, wherever they are. We had an initial loss for follow-up. These were the external ones, because they just forgot to call us and to report on is there any menstrual activity, and then we needed to recall them. And we've got 7 clinical pregnancies and births as well. So what about our follow-up? We tried to get all this information, and we would like to see hormonal activity after 4 months after the transplantation. In case there is no menstrual activity reported, we measure estrogen, LH, and FSH and wait up to 8 months. If we don't have any kind of activity, then there will be a second transplantation. So we try to transplant between 3 to 4 strips or 5 strips in the first transplantation, so there is remaining tissue cryopreserved. And the patient should inform us about spontaneous pregnancies, perhaps ART cycles performed, etc. Okay, and now here's a special case, and yes, I think you will like that. This is a young patient, and she's got some cancer of the gut. There were a lot of surgeries in childhood, and radiation also was performed, and there was no way to transplant the tissue in the peritoneum. So what to do now? We needed to find another place, and the other place was the arm. And here it is. So after 4 months, we could measure lower FSH and LH levels, and the patient reported some kind of tension in the arm. And there we started then to look at that. Can you see that? Okay. So here we go. And now I will show you an ultrasound scan as well. Yes, it works. So this was the follicle in the arm. And we tried an ovum pickup for about 4 times. We had cumulus cells, but unfortunately we had no mature oocyte in there. And now we are just thinking about the next transplantation in this patient. Yes. And now I would like to thank for the attention, and I would like to show you some of our babies. So the baby on the right one is the first one in Germany. That was born in about 2012. Now she's grown. And the lower twins are our first babies in Düsseldorf, born in 2017 after a lupus case in the young female you can see here. So thanks for your attention, and I think there will be a lot of questions.
Hi, that was really inspiring and just cool. But my question is pertaining to selecting reimplantation based on the disease and the risk for reinserting malignancy. And so a lot were breast cancer patients I saw, but there were some leukemia, lymphoma, and then, so I think more specifically about leukemia patients, which are always worried, but also there's some data on solid tumors, and particularly metastatic solid tumors that aren't in the ovary on imaging, but that they have done some stains and there's hints that there are some malignant solid tumor cells on the ovary. And so how do you select for those?
Yes, that's a very good question. So there's always one part of the ovary sent to the pathologist at time of the surgery. And in case there are malignant cells, then yes, we need to talk with the patient and we need just to pay attention on that. And hopefully for the younger girls, I hope that in vitro growth models will work soon. And sometimes there were, I think, about 2 cases, then we clipped that. So we marked the site of the tissue, and the tissue was then eliminated 2 years ago again, so after the pregnancy.
So then just to clarify, so what do you do for leukemia patients? Are you just do a histologic examination, or do you use other techniques or flow cytometry, or?
Just staining. That's
just staining?
Yeah.
Okay, and also just to clarify, you always do that on the back end. Do you do that initially when you remove the ovarian tissue? Do you stain it then, or do you just preserve it and then you take care of this? You do this on the back end when you're about to reimplant it?
Yeah, the last one.
Okay, thank you.
This was a tremendously informative talk. Thank you. I really like the idea of doing a hole punch biopsy of the testis to get an assessment of what's going on. The picture that you showed had lots of follicles in there, the calcine stained. Is that how you typically, I have several questions, but it seems obvious that if, and this probably demonstrates my naivete about this, but it seems obvious to me, one, that sometimes your density of follicles would not be as high as that. There are so many follicles that any hole punch biopsy, it seems, would pick something up. So the question is, how representative was the picture? The second part of the question is, do you see variability across a strip of tissue, so that if you looked at a whole bunch biopsy and you saw no calcine stained eggs, would that necessarily indicate that there weren't follicles elsewhere in the strip?
Okay, thank you. Yes, 2 questions. So I will start. The photo was representative for patients up to 30 years in general. So what we also do is we measure AMH. And I've got the AMH level and I have got our count, and then we decide on time of the transplantation how many strips do we need to transplant to get the best chance for this patient in case of a childbirth. And yes, regarding the biopsy punches, we try to have these punches done on different spaces of the cortex. So it's just according, as you already mentioned, the density is not the same.
Yeah. Were those disaggregated, or was that an intact piece of tissue that you did the staining on? The calcine stain.
The calcine stain? So sorry.
Was it an intact piece of tissue?
Yeah, so I see, sorry. So those are these 3 biopsy punches that I take for the vitality testing. They are about 2 millimeters. And the patient also has these 10 strips frozen. So they are not taken from the frozen ones. And okay. I can't use them later on, so they are just used for the staining. Right. That's vitality staining.
And just a curiosity before I give up the microphone, has there ever been a live birth from an ovarian tissue that was transplanted under the arm skin or some other place in the body that is not in the abdomen?
No, unfortunately not. So there are some case reports about the arm and about the bottom, but not with a live birth yet. No.
Wonderful. Thank you so much for this information. I'm Erin Rowell from Lurie Children's in Chicago. I'm a pediatric surgeon, so I remove the ovarian and testicular tissue in young children. My question is, what is the youngest age female patient that you have had tissue harvested that you have retransplanted? And then second, and specifically I'm interested, has there been a prepubertal patient yet? And then the second question that I have practically is, have you or your surgeons decided that the peritoneal pocket was the desired location for transplant because of the just the technical ease and facility of that location? Is it also because it's accessible if you then need to go through with IVF, or what was the reason to not transplant it on the other ovary? And I'm assuming from what you said, because you said there were several that were natural conceptions, that they still conceive through that peritoneal pocket.
Yeah.
Thank you.
Okay, thank you. Starting with the first question. The youngest girl at time of freezing was 1 year old, and the youngest patient with a transplantation now for us is about 17 years old. So I don't have the data with the prepubertal girls now. There are 2 cases, I think, worldwide with prepubertal ovarian tissue being transplanted, and we need to wait for these data because these girls are quite young at time of freezing. And then I think it will take about 20, 25 years for them just to get retransplanted if they need that. And regarding the second question, the surgeon technique, so it's a quite long history of transplantation in Europe already. And the first work was done on the remaining part of the ovary, and they were not that good in angiogenesis and vasculogenesis. So there was some struggling within. And therefore, this technique was invented with a peritoneum pocket, and it worked quite well. Really, yes. It's easy, it works well, and there is no problem.
Okay, wonderful. Thank you.
You're welcome.
Just with the heterotropic question, so there was that birth in Australia where it was implanted into the anterior abdominal wall, the first heterotropic. So it wasn't intra-abdominal, it was extra-abdominal, extraperitoneal.
Can you say that again? We couldn't hear you. I'm sorry.
Oh, sorry, I think I had more of a question about the heterotropic pregnancy, because there was that report by Stern et al. With the tissue planted in the abdominal wall. So it was extraperitoneal. That was 2000 and, do you remember? Maybe 2000, a few years ago. Yeah.
Quick question.
Yes.
So the high loss to follow-up,
Yep.
that surprised me a bit, but ultimately, were you able to follow up, or they're just
Yeah.
gone? Okay.
We were able to follow up, so this was the initial loss of follow-up because they just forget to report the data. Yeah.
Thank you.
Yeah.
Thank you so very much. That was wonderful.
very much.
Thanks to our speakers.